ICU, aiding but necessary skill. And to speak on that topic, we have Dr. Vinod Kumar Singh with us. That doesn't need any introductions as one of the doyen of intensive care in India. And Sir is currently a co-chair of the Institute of Critical Care Medicine and the director of ECMO program at Sir Gangaram Hospital, New Delhi. He serves as a member of the board of management of Sir Gangaram Hospital, and he is a country representative of Swayakeslo. He is also a past chairman of ICCM Delhi branch and faculty for the ICCM Fellowship Program in Critical Care Medicine. His key area of interest and expertise is ECMO. So, welcome, sir, and the stage is all yours.
Thank you, Dr. Sudipto. Am I audible to you, everybody?
Yes, sir, you are.
So thank you first, Dr. Tapesh and Dr. Sudipto for the kind introduction. So what I'm going to talk about the chest X-ray. My talk is limited to the chest X-ray related to the intensive care unit. So because it is a very vast subject and we will talk only the relevant part of the chest X-ray which is used day to day in the ICU. And what I'm going to talk about certain general principle, how to approach. We'll consider some normal X-ray and some common X-ray findings. So if you look at the chest X-ray in ICU, how it is different from the PA view, which is the standard frame. So these patients are prone to several cardiopulmonary disorders, the intensive care unit patients, and there is alteration in the physiology. Also, there is alteration in the pulmonary vascular, in the spine position. And also the most important is that there is incomplete inspiration. And a lot of shadows you can have. You can have aerospace shadowing in the ICU patient that maybe looks normal, maybe some abnormal things. So the first thing is that how to approach the intensive care X-rays. So what we do, and most of the ICU specialists does it, it is a DRS ABCD approach. So D is the detail, R is the look at the rotation, which is very difficult to find in AP view. Look at the soft tissue and bony cases, then go to the airways, look at the breathing, look at the infiltrates, consolidation, collapse, nodules, any pulmonary abnormalities, look at the circulations, pulmonary vascular circulations, and finally diaphragm and everything else like what are the devices present. And also compare the X-ray with the previous X-ray. That is also very important. And this approach has shown that it improves the diagnostic accuracy of the chest X-ray. And also it can be used as an enhanced communication because everybody who is looking in the X-ray in the ICU, they are talking in the same thing and in the same way. That improves the communication in the intensive care unit. So we all know that the X-ray, if you look at the PA view, you can see certain structures like you can see the trachea in the center, you can see the carina, and you can see SVC, also the right atrium of the heart border. Then you can see the left atrium and the left ventricle and the right ventricle. You can see in PA view the oblique fissure in the right side. Also, you can have some idea about the IVC, which is touching the base of the right heart. Obviously, you can see the right hemidiaphragm and the liver and the left hemidiaphragm, and also you can see the gastric levels. So these pictures you should keep in mind, which are the normal X-ray, when you are trying to understand what is happening to your patient in the intensive care unit. Now, determining the quality in AP view is very difficult, but you should actually try to assess, is there any severe form of rotation? It is an inspiratory film or it is an expiratory film, or what is the type of penetration? What most of the people does is go for a RIP approach, that is rotation, inspiration, and penetration. That tells you something about the quality of the X-ray. And a good penetrated view in PA view can see up to the thoracic vertebra, and you can see the spine through the heart, the thoracic spine through the heart. Also, you can see up to the 6th anterior ribs in the PA view and can go up to the 10th posterior ribs visible. Remember, these things are not visible most of the time in the AP view, which is taken in the sitting position or many times in the supine position in the ICU. Now, Many times, examiner or we also are confused whether it is a PA or whether it is an AP. Now, clavicle, if in the PA view, it is over the lung fields, and AP view, it is above the lung field. The most important structure is the bilateral scapulocyte. In PA view, it is always away from the lung field, and in AP, it is always over the lung field. Ribs in the posterior ribs are very distinct, and here the anterior ribs are very distinct in the AP view. The heart is relatively enlarged in the AP view. So when we are examining the heart, AP view is not adequate exam. Now we must determine whether it is an apparent rotation or it is a real shift of the mediastinum. So if the trachea is not centered, then you should look at whether the film is rotated or there is a real shift of the trachea. And you should draw a line from the both clavicular head, and you should see whether the spinous processes are in the center or not. And that tell you whether it is apparent shift or whether it is a rotation of the film. If you look at here, that there is a large opacity in the left lower zone of the lung, and also there is a severe shift of the mediastinum. And also there is a shift of the trachea on the right side. It is a real shift because of the push of the fluid which is there in the left side of the lung. Now coming to the first thing, which is the chest wall and the soft tissue, we should look at the rib fracture, also surgical and some subcutaneous emphysema, soft tissue swelling, and the flail chest, particularly in the trauma patients. Look here, you can see that there is a flail chest and there is a fixation of ribs. We should not miss it. And this, you can see that there is some instrument or something killing object which is in the soft tissue, which has not penetrated the lung. In the right side, you can see that there is a multiple rib fracture leading to the tension pneumothorax, and there is also shift of the trachea. The soft tissue are very, very important to see. And if you look at here, you can see also again, there is a fracture. Most common rib fracture is the 4th to 10th rib, which is fracture in the trauma patients. Also, if you find that there is a first, second, or third rib fracture, and particularly if there is a first rib fracture, this indicates that there is a high energy of trauma and there is an associated vascular and mediastinal injury. This is again a trauma patient. You can see all the findings which occurs in trauma, rib fracture, there is a pneumomediastinum, there is a chest tube, and also there is a large bilateral subcutaneous emphysema, mostly on the left side. And so these are the importance of looking at the subcutaneous spaces in patients with HIC. The next part is the airway, and the mnemonics of the airway is A for airway, position of the trachea, I is the intubation, endotracheal tube, any foreign body. Right is the right mediastinum intubation, wide is the widening and narrowing of the trachea. A is the aspiration signs, and Y is the biseparate carina. These things should look. This is the normal endotracheal tube position. You can see it goes up to the sixth rib, and anteriorly it can go up to the sixth thoracic vertebra. The trachea is usually central, and it is most of the time 5 centimeter proximal to the carina. This is the tracheal tube. Endotracheal tube is 5 centimeter proximal to the carina, and you can see the cuff also. The cuff look like some air in the X-ray and black space. Again, you can see there that the endobronchial catheter has been passed in the right main bronchus, and this is for the chest surgery or sometime for the hemoptysis. We do it, and if we look at going to the lung parenchyma for the explanation or for the explaining the lung region, we can divide into the 3 zones: the upper zone, middle zone, and the lower zone. The level of the interior end of the second rib remarks the difference between upper and the middle zone, and second to fourth anterior ribs is the middle zone, and below that is the lower zone. What we describe in the X-ray is based on the zone. It doesn't correspond to the lobes, but it is described mostly in the zonal area. Now, if you look at this, some of the soft tissue lesion and some of the changes in the translucency, if the lung is unilateral hypertranslucent or hyperlucent lung, what are the differential diagnoses? The differential diagnosis is can be soft tissue, can be lung, can be thoracic cage also. In this X-ray, you can see there is a right-sided mastectomy, and second one, left side, there is a left-sided lung transplant, and there is a compensatory hyperinflation on the right side. Again, because of the right-sided mastectomy, the right side soft tissues are absent, so the right lung is looking more black. And it is not hyperinflated because of the absence of the soft tissue, it is looking like black. However, in the other one, where there is a lung transplant, there is a hypertranslucency because of the hyperinflation of the right lung. So what could be the region? It could be chest wall, it could be mastectomy, Poland syndrome, it could be a compensatory hypertension, it could be opposite atelectasis, or it could be a pneumectomy of the opposite side, could be the pneumothorax on the same side, or nematocele on the same side, or partial agenesis like Swyer-James syndrome. Mostly we see pneumectomy, pneumothorax, and mastectomy also sometimes atelectasis. If you look at here, this is very rare finding, but again, you can see the right upper lobe is getting more and more black. And this is a Western mark sign of the pulmonary embolism, but rarely find because of the leukemia. So sometime if you have a leukemia of the same side, you will have a, looks like an apparent hypertranslucency on that side. Again, unilateral hypertranslucency, the most dangerous cause is the pneumothorax. You can see that there is a pneumothorax on the left side, and this is a tensor pneumothorax because the mediastinum is also sick, diaphragm is getting flattened. Look at here, sometime what you find, there is a hypertranslucency of the lung field. Also, you find there is a blackish rig on the right side. This is not a hyperinflation because this is an exposure, and this is an abnormal exposure on the right side that causes apparent blackish of the right side, and it is not a lung pathology. It is the problem with the machine and problem with the keeping the plate. So we should not worried about that. If ribs and lungs both are looking black, there is some problem in the exposure. Again, hypertranslucency on the upper lobe, you can see that this patient has got a COPD, and you can find the bulla, and also it causes localized area of hypertranslucency. Some typical bullets can cause several localized area of hypertranslucency. Here you can see in the upper zone and the mid zone. Again, we talk to the pneumothorax, how you can confirm the patient has got a pneumothorax, not only hypertranslucency, but the collapsed lung margin. You can see that there is a very beautifully depicted collapsed lung margin, septing the trachea and mediastinum towards the left side in the right side of X-ray, and there is also left-sided pneumothorax. There is a collapsed lung margin. You can see the line which is depicting the collapsed lung margin here. Sometimes you can see also the bilateral lungs are hypertranslucent, and the most common diagnosis is COPD because of the large bulla, because of the hyperinflated lung. Also, you can see bilateral hypertranslucency in cases where the patient who has got a bilateral lung, a bilateral pneumothorax, and this is a very, very dangerous diagnosis. Nobody should miss it, because missing means more and more hemodynamic compromise, hypotension, hypoxemia, and finally, if you ventilate this type of patient, they might end up with a cardiac arrest. So we should not miss hypertranslucency, bilateral hypertranslucency. Now, after the translucency, you should come to the unilateral opaque lung. So what happens if one side is white? It could be pneumonia, because in pneumonia also there is a consolidation. You will find there is no mediastinal sept and there is a symmetrical intercostal spaces. It could be a effusion, or because you can see a large effusion can shift the mediastinum towards the opposite side. It could be atelectasis also. You can see that the atelectasis, the mediastinum is shifted towards the same side. So opaque lung with a no sept, probably pneumonia, opposite sept diffusion, and same siding septing, probably atelectasis. There could be more other causes like pulmonary aplasia, like agenesis, and also like pneumectomy. So these factors can cause a unilateral opaque lung. And if I look here, that the left-sided lung is opaque in one X-ray of the left side, and there is a pull of the trachea because of the collapse. The other X-ray, white out again, but the trachea and mediastinum is shifted towards the left side because of the large pleural effusion. So you can see here that opaque lung differential diagnosis depends upon how the trachea and the mediastinum is shifted. whether it is shifted or not shifted. Again, look here, the large effusion on the left side causing shift of the trachea and causing shift of the mediastinum and other part of the lung also towards the right side. So again, we should consider X-ray mediastinum, how it is mediastinum is shifted, not shifted, or shifted, whether it is opposite side or the same side, ipsilateral or the contralateral. If you look at the total collapse of the this X-ray, the mediastinum is shifted towards the ipsilateral. Again, it is the collapse and right bronchial margin is not visible. And look here that also the two things you can see that a large pleural effusion causing shift of the mediastinum by pus, and right sided also you can see there is a collapse of the right upper lobe. So pulling the mediastinum more and more towards the right side. One factor is pushing, and another factor is pulling towards the ipsilateral side. You might find the combined pathology in lung cancer and other diseases. Now, bilateral white lung is very, very, you can see severe condition. You can see here that the lung fields are white bilaterally, and also these patients are quite hypoxemic, mostly on the ventilator and the tracheotomy. Here you can see that with the bilateral white pill, you can see that both the patient is on ECMO. You can see lower is the drainage cannula, and the upper red one is the reperfusion cannula, and this patient is in ECMO because of the ARDS. So mostly bilateral white lung is bilateral pleural effusion, large or maybe bilateral pneumonia, or mostly it is a severe form of the ARDS. So what happens if there is a lobar of the segmental ossification? It is mostly due to the consolidation or atelectasis. It is the commonest cause of the pneumonia. Sometimes you will have a pseudosegmental opacity also. Many times you'll find interlobar effusion, particularly in the right side interlobar fissures, and also sometimes the loculated pleural effusion. So pulmonary opacification patterns you can recognize. It could be alveolar, it could be interstitial, it could be a nodule, or it could be a multiple nodule, or it could be atelectasis associated with opacification, or sometimes atelectasis associated with consolidation also, or alveolar opacification. It is not necessarily you will find that separate type of lesion. You might find mixed lesions, particularly in intensive care unit. Look at the type of lesion you can see in the X-ray, and you can see there is one type we have already discussed is the aerospace opacity. Mostly it is pneumonia, and sometimes ARDS also, pulmonary edema also. You can see the key features are alveolar opacity, air bronchogram, and patchy or lobar opacity, and common causes pneumonia and pulmonary edema, ARDS type of things. Interstitial pattern. The key features are reticular, auricular, nodular pattern. You can see mostly it is the interstitial lesions, and mostly in the interstitial. And you can also see sometimes the curly V lines, peribronchial cuffing. Atelectasis is different. You can find out the volume loss, you can find out the shift in the fissure, you can find out the elevated diaphragm, as you can see. The common cause is the mucus plug, obstruction, post-operative, and the poor inspiration. Now, consolidation, most common findings you can see in the X-ray. It is defined as the replacement of the gas with the airspace by fluid, protein, cells, or other material, characterized by the presence of air bronchogram and homogeneous shadow, and it is associated with obscuration of the pulmonary vessels and little or no loss of volume. See here, you can find the different type of consolidation, the ill-defined patchy opacity. There is a coalescent area of consolidation sometime. You can also find sometime, you can see the green one, that the large consolidation, some area is fully consolidated, some area is going on developing the consolidation in this area. So you can have different type of manifestations in the consolidation, but always try to find out air bronchogram, always trying to determine whether there is a volume loss or not volume loss. Again, you can see that bilateral consolidation with beautifully detected air bronchogram. This is a typical bilateral pneumonia. If you find such type of X-ray, there is a bilateral pneumonia, which is causing consolidation. You can also find the silhouette sign here. We'll discuss later on. Again, you can see pneumonia X-ray in the X-ray pneumonia can have a lower pneumonia or lower consolidation, like S pneumonia, Klebsiella pneumonia, or Legionella. You can have a bronchopneumonia, Staphylococcus aureus, E. coli, or anaerobics, and also you can have an interstitial pneumonia. You can see mostly interstitial sacs like mycoplasma, viral pneumonia. So viral pneumonia starts always interstitial pneumonia. Now, ground glass opacity. COVID time, you have found that many discussions on the ground glass opacity. What is ground glass opacity? This is a homogeneous opacity that do not obscure the underlying pulmonary vessels. And the ground glass opacity may result from the partial failing of the air spaces, and it frequently reflects the presence of predominantly interstitial abnormality or the alveolar abnormality. If you look at the pathogenesis, the partially filled area, you can see the X-ray looks like that it is not fully consolidated. You can see that the vascular structures are quite okay. There is no distortion of the vascular structure. And also you can see how the CT scan looks like if the patient has got a GGO or ground glass occlusions. Now, something about the silhouette sign, usually not visible in the AP view, but you can see in the PA view when opacification is situated in any portion of the lung adjacent to the mediastinum or the diaphragm, it actually obscures the border of the mediastinum and diaphragm. And if it is there, we call it positive silhouette sign, and it helps in localization. You can see here that the left border obscuring the left border. So it is again the silhouette sign positive. You can see here that right upper lobe, right heart border is not visualized. And you can see the right, if right heart border is not visualized and some of the superior vena cava are not visualized, you can say that the disease is in the right upper lobe. Again, there are different area of lung localization, like you can see the right auricle, which is in the yellow, it is the descending aorta, also left auricle, also left ventricle in the blue. So if these structures are not visualized, they correspond to the lung. Like if the yellow structure is not visualized, right upper lobe, green one is middle lobe, and also you can see the orange, the large lingular, and the lower lobe. So these things you can see only and only in the PA view. They are not visualized, and we cannot interpret it in the AP view. Coming more to the interstitial infiltrates, these are the inhomogeneous, these are the diffuse, discrete. There is no air bronchogram, reticular, or nodular. And differentials include fibrosis, sometimes connective tissue disorders, radiation fibrosis, asbestosis, lymphangitis carcinomatosis, biliary tuberculosis, silicosis, viral pneumonias, and so many things. What are the different patterns we can see in the ICU? You can see A is the linear pattern that you can see here is the curly B lines, which is the thickened connective tissue. You can see in the B the nodular pattern, the fine nodular pattern. You can see in the varicella pneumonia and different types of also. You can see the reticular nodular pattern. Both nodules and reticular shadows are present, and these are the mainly lymphangitis carcinomatosis. And last one, the D, which is seen many times in the ICU respiratory ward, is the honeycomb. It's the coarse reticular nodular shadow. So coarse reticular nodule, thickening of the bronchial wall, distortion of the lung parenchyma, all suggest honeycomb. Something about the pulmonary edema, because they are presented to the ICU with respiratory distress. What you find in the X-ray is the upper lobe diversion of the vessels. We call it cephalization, and also battling, diffuse infiltrates, and associated with pleural effusion, septal lines or early B lines. You can find the thickening of the fissures and peribronchial coughing. And you can see here all the findings that starting from the center going to the periphery, you can blue arrow showing that there is interlobar effusion. You can see that there is a bilateral costopenic angles are absent, and other one, the white, is showing that there is a curly B lines are present. Also, CT ratio is altered if the pulmonary edema is due to heart failure, and you can measure the CT ratio like this, and more than 50% suggest the heart is enlarged. Already we have discussed, but Non-cardiogenic pulmonary edema, it is different because there is no cephalization of the blood flow in the non-cardiogenic pulmonary edema, and it is a diffused. Mostly you find air bronchogram and typically occurs 48 hours or more after the initial result, like if the patient has a unilateral syndrome that has gone to the bilateral and the patient has gone into acute respiratory distress syndrome. And mostly once the patient starts improving, it takes weeks together to improve, which is different from the pulmonary edema, which improves in days. Again, post reticular opacity honeycombing, you can find that here. There is a mostly sarcoid or the chronic interstitial lung diseases that presents as a course
We have
nodular
5 minutes
sinus.
left.
Okay, sure. And now this you can see that bilateral upper lobe cavity, you can see here that the bilateral patient with hemoptysis, you can see there is a distortion of the lung parenchyma, the trachea is deviated towards the right side, and you can see right side large cavity patient has maybe some mucus ball here or aspergillosis is present. Pleural effusion, again, common finding in the ICU to define it is a homogeneous opacity seen to track along the lateral chest wall. The postoperative angles are arbitrated. The meniscus sign is noted, and there is absolutely no air bronchogram, and there is no volume loss. You can see here the meniscus sign and effusion. This is typical finding in pleural effusion, particularly in PA view, but AP view is different. Patient is supine, so you'll find that it is not clear because the fluid moves towards all the pleural spaces. So it looks like some haziness. But if you take the sitting position, you can find some well-defined area of the pleural infection. Again, bronchopleural fistula, air and the fluids, you can see after lobectomy, after lunectomy, there is a air fluid level, and that is diagnostic of the bronchopleural fistula. In the right arrow, you can see that there is a air and there is a horizontal margin which indicates that the patient might have bronchopleural fistula. This type of X-ray is mostly in Paima because the air and fluid and pus are there after developing the bronchopleural fistula. Deep sulcus sign, something in the X-ray that you can see here that occurs in the pneumothorax on ventilator. You can see the right costopenic air is gone to depth. It is deep sulcus sign. And pneumomediastinum also, you should not miss it. You can see the margins of the heart, and you can see the air in the margins of the heart. This is suggestive of the pneumomediastinum, and he also about the pneumothorax. Again, here you can see that pneumomediastinum post-intubation in the COVID patient. Like some devices, I'll go fast that you can see here is the dialysis catheter is there. You can see here that the tracheostomy tube is there. You can see the position of the tracheostomy tube and how it is connected. You can also see that left central line in the correct position going to the right SVC. You can see here that a right-sided arrives to has gone the right bronchus, again taken turn and gone into the left side. This is a normal condition. And again, you can see the pacemaker, two wires. One is the RV, other is the LV. You can also should not miss this type of devices in the ICU. You can see also the right side SBC has got taken turn, and it is taken round turn in the subclavian vein. You can see here the catheter we have already discussed. The right upper is upper is the reperfusion cannula, and the lower is the venous catheter of the ECMO. Thank you very much and thanks Tapesh for giving me opportunity. If any question, I will try.
Thank you, sir, for an excellent presentation. We have one question in chat box that I just will reframe it. That presently we are doing on calls, we get a lot of time we get X-rays and other radiologies in our mobile. So as you mentioned, what I understand that probably with the change in the quality of the picture, the interpretation can be really different. Do you really feel we still try to use all those modalities to interpret or help our colleagues who are at the bedside?
Very, very good question, Dr. Sita. Once you have the mobile X-ray, and now before getting the film, you can see how is the X-ray quality on the screen. So this has actually changed the ICU practice, and we have more and more better quality of X-ray after mobile. And I think this has done a lot of things in the ICU, X-ray and molecular diagnosis in the ICU. And in our ICU, we are using mobile, and we are very happy that mobile X-ray has actually changed the practice of the X-ray.
And sir, one question from my side that as you mentioned, as we know, the sensitivity of X-ray is around 70% for most of the acute respiratory failure, whatever the etiology. So how we are going to use it in our regular practice? And do you suggest to do it regularly to follow up also in terms of respiratory function?
If you have X-ray, at least both in the OPD practice, medicine practice, and the ICU practice, actually, what I found, X-ray is the one thing which has mostly changed the intervention. Neither the ultrasound nor the CT has the power to change the intervention. Everyone has got the power to change the intervention, but the way X-ray keep track to you to ask the patient, that is very remarkable. Now, see, CT is very specific sensitive, but the question is how every patient should go for a CT every day. X-ray you can see every day. Ultrasound again, operator dependent. Again, so many things in the if pneumothorax, pneumomediastinum, post-operative. These things actually we do not find in X-ray. That's why still the intensivists are more and more dependent upon the X-ray.
So I think still it is a very important skill to acquire in our regular practice. It's definitely
Definitely.
not a
What I feel,
fading technology,
yes,
I guess.
yes. So far, no technology is going to replace the X-ray. And as long as this mobile X-ray has come, it has actually changed and made a revolution in the X-ray in the ICU.
Very well explained, sir. And and I think if we, for the sake of time, I
No,
think
it's
we need
okay. You take the
to.
questions.
Sorry.
You will take the questions. Two questions have come up.
Okay. So there are another two questions. That one is APView has widened mediastinum compared to PAView. So is there any particular cutoff for diagnosis widened mediastinum?
In PA view.
AP view. PA view or AP view?
APView.
No.
There's
Question
no
is,
cutoff for the AP view. All the description of the cutoff is CT ratio more than 50% is in the PA view. Nobody has described the cutoff view in the AP view. Because it is so variable, whether you are taking in supine position, whether you are taking in the sitting position. But what I feel, once the mobile has come, we need to redefine the AP view. We need to rethink about the AP view, whatever the AP view has been described in the previous one, which is the manual. But again, I think we should redefine the AP view, and we should restructure how to define the AP view in view of AI and the mobile apps. That will be the great achievement if we can able to do.
And sir, another question, if I may. So we know that the radiological recovery happens later compared to the clinical recovery. Do you have any time period or time lag that you can share from your experience? We know there is nothing documented in the literature that how much there should be a delay. Or what is your clinical experience?
In pneumonia or ARDS, what we are talking?
In pneumonia and ARDS, in alveolar pathology.
Alveolar pathology, radiological recovery is almost a week later, and there is a time gap of a week later in radiological and clinical recovery. We have seen that pulmonary edema is the one thing which can go side by side, clinical recovery and radiological recovery, because it is all fluid. Once you put the patient on ventilator, once you give the diuretics, X-ray clear, patient good, okay. But when there is a cell debris, protein, or there is some damage, it takes lung to regenerate, it takes lung to again do the things and healing. So maybe minimum 1 week difference is there, but maybe 2 weeks, not more than 2 weeks in kind of clinical radiological recovery. But why we do repeat the X-ray? Because we always try to find out is any new things in the X-ray. If the patient is recovering, there is no need to redo the X-ray. If you think that the patient is deteriorating, or you find that something new you have done, put a central line, put a something, then only you should go for X-ray. There is no need to repeat the X-ray. ICU setting, you can do very confidently, alternate day or whenever required. Once one X-ray is done, that's sufficient. No need to go for daily X-ray.
That's an excellent suggestion, sir. That will cut down the overall exposure of
Yes,
to
yes.
X-ray to our patients. I think if you don't have any question, Dr. Tapesh, if we can we
Yes,
wrap
yes,
up the
absolutely,
session?
Dr. Sudipta. Thank you. Thank you, Dr. Vinod Singh, sir, for covering this
Thank you,
topic
sir.
so nicely. Or so many
Thank you.
experts
Thank
you brought.
you.
Thank you.
Thank you, Vinod Singh,
Thank
sir.
you, sir.